Good afternoon, everyone. My name's Ajay. I have the dubious honour of giving the bulk of the two talks before lunch, so I'll try and keep it quick because I'm sure all of you are hungry. Also, thanks, Yves, for allowing me to give these first few slides with only a day's notice. I should introduce myself. I have finished my training as a cardiac surgeon, and really I owe you as a community my entire career, because I would not have taken this path if I had not begun my work with Yves, looking at the outcomes of you as a group, and then working with him to help create the registry and to come along for this amazing ride that the last 8 years have been? Longer, 12 years. 12, yeah. Time flies. When we say what can we do for our Fontanes, I think that I owe you everything, so thank you. It's also amazing to see the community that's been created and that continues to develop. It wasn't uncommon when I first met my first Fontane patient 12 years ago, having an exercise test, that they didn't know anyone else in the entire world who had a Fontane or a heart like theirs. Now, through groups like this, you have the opportunity to go up and talk to 4, 5, 10 other people and their families about what the experience is like, what life is like with a Fontane. And I think that's a fantastic thing. And finally, to say that I don't think I would be the doctor that I would be if I hadn't gone through this journey and seen what it's like to have a life with half a heart. And I'm really grateful for that opportunity. So the first part of Yves' talk was on anticoagulation. And it's something that I've been involved with from early on. So put your hands up if you or your family member are on warfarin. Okay, and put them down. And what about if you're on aspirin? So it's interesting. Here it's probably almost 50-50. If you went to Sydney, almost no one would be on warfarin. If you came to Melbourne, almost everyone would be on warfarin. So just keep that in mind. Now, Gavin said that we wouldn't have talks covered with old cardiologists, but I think it's worth mentioning Virkov. He wasn't a cardiologist, he was a pathologist, and he gave us a useful little tidbit that we still use every day in our clinical practice, and that is that clot, or thrombosis, is a triad of things. And you really need all three to develop a clot. So you need low flow or turbulent flow, you need blood that's slightly clotty, and you need a rough vessel wall or an abnormal lining of the vessel. And if you have all three, or a really bad situation with two of them, then that's enough to cause clots to form. And you've all seen these pictures about the different types of Fontane, and hopefully now you know which Fontane you have, but we know from our research that not everyone does. So the original type of Fontane, which is not performed today, the original type of Fontane is the atriopulmonary Fontane. Plenty of people still around with them, probably in this audience too. The modifications were the lateral tunnel and the extracardiac Fontanes, and the reasons for those modifications were partly because the atriopulmonary Fontane is a big floppy bag, the atrium, which tends to get bigger and tends to cause blood to pool and form little turbulent currents. And as you remember from Virkov, the old pathologist, it has all three of those issues. So the atrial wall is rough. We know that in people with a Fontane circulation, the blood tends to be a little bit too clotty, and that's why we have you on blood thinners. And the turbulent flow in the atriopulmonary Fontane is the perfect situation to create a clot. So as I mentioned at the beginning, different units, different doctors have different recommendations about what the best type of anticoagulation is, and that's because the evidence is not great. There's really only one trial, and that was one of the 5 trials that Yves mentioned that has a large number of people in it with a Fontane that was performed by Paul Monagle at the Royal Children's Hospital, and I think it included multiple sites in Australia and overseas. And it didn't show any huge difference between aspirin and warfarin, but it was a small study. They had difficulty getting enough people in, and they looked for clots using a test called a transesophageal echocardiogram, which is an invasive test that we don't perform unless we absolutely need to, and it didn't necessarily look at actual clinical events of strokes or clots in the lungs. We definitely know that some form of anticoagulation is much better than no form of anticoagulation, because this squiggly line looks bad and these squiggly lines look much better. We also know that being on warfarin that is not well controlled, so not with levels that are consistently, INR levels that are consistently in the correct range, is worse than being on aspirin, and this is all from that study that was performed by Paul Monagle and Brian McCrindle. During my PhD with Yves, I looked at the data from the Fontaine Registry, which many of you have contributed to, possibly without necessarily knowing, because the registry automatically includes your data. And what we found was that the rate only in atriopulmonary and in lateral tunnel and extracardiac Fontaines, the rate of blood clots was only 9% at 12 years. And we used some fancy statistics to match the two groups of people, select patients within those two groups that were broadly similar, and showed that we couldn't really find that one was better than the other. What we did find was that most of the events of blood clots happen within the first year, and that makes sense because around the time after the Fontaine operation, the anticoagulation with warfarin can be a bit unstable. There are multiple changes happening with the heart function, with general health, with nutrition, and it's possible that that's the reason that that's the highest risk period. And beyond 1 year, there's a mix of different things that are happening. Some of them cause symptoms and some of them are silent. They just picked up on ultrasounds of the heart. But what we did find through this was that there was a regular occurrence of bleeding, and that almost all of the bleeding events happened in patients on warfarin. Again, I only had 2 days' notice, so that's all the slides that I've got for this, so I'll get Yves to come and give the rest of his talk. And I'll be back in a minute.
Thank you very much, Ajay. I have to mention the fact that even though the building up of the Fontaine Registry has been associated to my name, Ajay was the guy in the background doing all the hard work. I was, getting the fame for it, but he was doing the work. And I hope that he's beginning his career. You're going to see a lot of him in the future. So I'm going to present you a work of Chantal Attah, who's done a PhD on anticoagulation in Fontaine, and she's presented a completion seminar, and I'm going to present her results because she's having a second little baby at the time now. So the thing to let you know, I'll remind you, for those who haven't been to the previous education day, the system, how research works is that when you participate in research, it takes a lot of time for you to get the feedback. Typically, you participate in research, you may be one of the first patients participating to the study. The study goes along and recruit patients for 1 or 2 years. Then we take us 6 months to a year to analyze the data and get the results. We send an abstract to a national meeting. Take us 3 or 4 months to know whether our abstract is accepted. It's presented about 3, 4, 5 months later. At the same time, we present our paper, and our paper will get published about 2 years later after what we call peer reviewing process. So our article is reviewed by peers, people, doctors like you, which means that between the time where you participate in the study and the first time you get the results, about 4 or 5 years, easily. And so what we're trying to do with this day also is to cut off this process. So what I'm going to present to you are raw data that have not been peer-reviewed. We do not have analyzed yet even all the data. These are preliminary findings, and you have to keep that in mind, okay? Good. So we did what we call a cross-sectional study. So we got the people coming back and did some tests. And it was through multiple centers throughout Australia. So we wanted to know how many of you had bad clotting events, which mean stroke. We wanted to know whether aspirin or warfarin was more effective in preventing strokes or other events. And we wanted to see if the people having warfarin had less bone density. We know that there's a process with warfarin that you have a decreased bone density. And if you have a decreased bone density, it's like old women having, osteoporosis, as we call that, they can have fracture. And we wanted to see that. And it may be amazing for a drug that has been for so long around, but the studies in children are there's very little. And none of them in a group of patients who has the same conditions. So that's the first time that was done in a patient with the same conditions. We wanted to see if the patients with warfarin had increased bleeding, as it seemed to be the case in the retrospective study that AJ had done. And was the quality of life different if you take warfarin and have these multiple blood tests compared to aspirin? So we recruit the patients between 2014 and 18. They were all patients in the registry, more than 5 years after surgery and more than 13 years of age. And mostly we concentrated on Melbourne, Sydney and Auckland, and that's because just the majority of the patients are there and it's just more convenient to do that. So all the scan for the MRI, so we do brain MRI, were all reported centrally, so the one same person looked at it, somebody who's got expertise in the field. So what are the results? So now is the scary bit. So almost every single patient we looked at the brain scan had some degree of brain abnormalities. Okay, don't be scared. It can be very small. 96% had microhemorrhage. 38% had images of stroke, but only 5% had clinical stroke. So we quote to every single open heart operation about 1% risk of having something flying by and causing a stroke. A stroke doesn't mean that you're incapacitated, cannot move a limb or something. A stroke means you can see something on the brain that was not there before. And the clinical one, where you can detect something, fits with having a more severe cardiac condition than the usual cardiac conditions undergoing cardiac surgery. And 87% of the stroke were completely asymptomatic. Even if you try to detect with fine motor skills and fine cognitive skills measurements, you cannot detect anything. There were no difference between patients with warfarin and aspirin having stroke. So I'll give a little example. These are the kind of things you see. There can be some more major things here. It can be tiny things. So you would have tiny spots like that and be considered to have a stroke, even if you have only that. Okay. I'll give you 2 examples of stories. Okay, so if you're a scuba diver and you have a PFO, a hole in your heart that 30 to 40% of everybody has, so because you're born with that and you have a tiny hole where the air can go from one side, well, you can detect in all of the patients all the people doing scuba diving who have PFOs, you find the same lesions. I'm a scuba diver. I'm not completely debilitated. I've checked my PFO. I don't have a PFO. So, but to tell you that that's something frequent. I'll tell you another story. I have a very good friend of mine. At the time of birth, their child had missing. You look at the CT. You look at the CT of the head. A complete half hemisphere was absent. So you see a black hole in half of the brain. And they were terrified, and the people were not optimistic. This kid grew up with my own kids, and she's got a little bit of deficit on the left hand. She needs a little bit of work with splint, sometimes wearing for the left foot. She's otherwise absolutely normal. She's integrated. She's got to work now. There is an enormous plasticity, and we know that. So all that to say that, yes, if you are born with a fontan, your brain MRI will be abnormal. If you get one for another reason, don't be scared. That's part of the deal. That doesn't mean that you're not going to function well. It's an imaging, okay? So the majority of the stroke were asymptomatic, and stroke rate fits with previous study. We don't know when that happens, and that's the topic of a whole set of work. It can happen before birth if you have very mild heart conditions like transposition of the great arteries. You see abnormal scan in a lot of patients before we even touch them. Okay, so something may happen before delivery. We know that things may happen during the surgery, but we know all the area where we have to look for, but we do not have the answers at this stage. So we look at the bone density with sophisticated examination, the same examination DEXA that Rachel talked about, which allow you to get this idea about the muscle mass and the fat content of your body. And so the results were the following. The patients on warfarin had lower bone mineral density in all but one measure site. We look at different sites of the body. But the fracture rate seems to be the same between all the groups. Apart from the right ankle, so we can see that there's microfractures that have been healed. But there was more signs of fracture in the aspirin groups, which we thought maybe the guys on aspirin were doing more contact sport and more things that are a bit more dangerous, and so that's what you get if you're actually more active. It may be that the patients on warfarin were prevented to do some more heavy sport. So we knew that it was reduced. It's not a big surprise, and as I said, it's maybe related to difference in physical activity level, difference in fracture we observed. So the effect on bleeding, so we looked at with a very specific questionnaire, so much more than just collecting the data in the file as we did. So we had a very precise questionnaire for that. And patients on warfarin had more nosebleed, and that's the only difference we could find. So we could not confirm that there was more major bleeding events in this more detailed study. So there is a difference, but it's minor. Interestingly, menstrual bleeding severity did not seem to differ between patients on warfarin and aspirin, and I can say that we had that question recently on a Facebook page, and so that some people are asking themselves this question. The effect on warfarin on quality of life, again, the team in Melbourne had developed a very specific questionnaire to see how much it impacts life to be on warfarin. And what they found that there was no difference, and that was a surprising finding for me. There was no difference between being on warfarin and aspirin. I think that's just a testament to a testimony of how much a good work the doctors taking care of you on warfarin is doing. Because, you know, for me, it's obvious, you know, you get more blood tests and things. It looks like a harder work, but you get on your life, it doesn't seem to be affecting your life. That being said, if you reanalyze all the data and you look who is on home INR monitoring, there is a difference. It seems like the fact that there's not such a difference to me is related to the fact that a fair number of the people on warfarin have home monitoring, because the people on home monitoring have definitely a better quality of life than the people who have to go back to the hospital or their local practice for all the tests. So no difference in quality of life, but home monitoring program giving a difference. That's the very summary of this analysis. No difference in stroke or brain injury between the two. A difference, people on warfarin have lower bone mineral density. They have more bleeding, but again, only minor bleeding. Quality of life is the same in the two groups. So we need to dig in a little bit more, especially in the brain MRI of these patients, to find out whether we find any correlation between these brain lesions identified in the MRI and really functioning, what you guys are doing. And is there any relationship between bleeding events and exercise and what you do in life? And so we got some money from HeartKids to look at more details of the brain MRI we have collected, to do this super duper fancy image instead of looking just at, you know, plain MRI, to get an idea of the functions. How much gray matter do you have? How much white matter do you have? And if that's not more important, if you look at more fine details, can you find out what's determining having more or less gray matter? And these, on the left side, these very exciting images of tractography, which gives you a function. It's not only how you have the image of your brain, but how does your brain deep inside function, because you can have the similar image on the brain and having completely different functional tracts inside your brain. So that's the future. We get the answers pretty soon. Thank you very much.